It was nice to have that extended break. I was able to kind of get up from my chair, go for a little bit of a walk. So it was a nice segue, perhaps, into this session, which is going to be dedicated to physical activity, exercise, and dementia. Before we get going, just kind of want to report that there are no conflicts or disclosures here. And I do have a set of learning objectives, which I will verbalize now. Specifically, what I'm hoping that observers and those that are engaging with this presentation can take away from is describing the difference maybe between sedentary and physically inactive, perhaps having some acknowledgement with barriers to being physically active, and describing the role of physical activity for dementia. Although I had a very nice introduction, I do want to have a self-greeting. So, hello, my name is Ryan McGrath, and I am an associate professor here at North Dakota State University, specifically the Department of Health, Nutrition, and Exercise Sciences. I also direct a lab here at NDSU titled Healthy Aging North Dakota. That lab engages in a variety of topics related to aging and health, but more specifically, the prevention and treatment of age-related disease and disability connected to the musculoskeletal and neuromuscular systems. Have very good collaborations with the University of North Dakota, have a faculty appointment at the University of North Dakota School of Medicine and Health Sciences, specifically geriatrics, and then similarly to the Fargo VA healthcare system. So we're in January. For me, when I'm in January, I think a little bit about winter, but I also reflect on a lot of things. And one of those things, similar to probably many others, is my physical activity habits and exercise. And physical activity oftentimes can come in many forms, many types, for example. There can be aerobic physical activities, which may include cycling, running, elliptical trainer, walking. There can be maybe some activities that have a little bit more of a resistance focus that may include weights or even body weight, resistance bands. There's flexibility training, there's balance, but there's also some similar characteristics too that factor into physical activity participation, exercise, such as frequency of physical activity. What is the intensity of physical activity? Is it light? Is it moderate? Is it vigorous, for example? And the duration of physical activities, such as how long am I engaging in a bout of physical activity? So lots of things to consider apart from just examining frequency, intensity, type, and time of physical activity as pertains to participation of physical activity now that we're in the new year. So starting out a little bit with some terminology, and there tends to be a little bit of a difference between physical activity and exercise, such that physical activity, for example, just might be movement that would help to maybe have a little bit of an energy expenditure attached to that movement. Specifically, exercise, though, may have a little bit more planning, a little bit more structuring, a little bit more of a repetitive movement, for example. Maybe the intensity of exercise as pertains to physical activity intensity might be a little bit more elevated. But I will say in my experience that I oftentimes do observe maybe physical activity and exercise, those two terms kind of being used interchangeably as a whole. But it's nice to note that there might be a subtle difference between the two terms. But physical activity exercise does help to contribute to physical fitness, and there's many domains that would contribute to health, for example. Physical fitness may contribute to physical health. It may similarly connect to maybe other domains of health, such as maybe mental health or cognitive health, for example. And then likewise, alternatively too, there can be some situations where other domains of health may connect to physical health, such as social health, maybe supporting physical health and supporting physical activity participation. So on the previous slide, we had some terminology that was dedicated to helping to maybe operationalize physical activity and exercise, whereas here, we're going to be looking at terminology that might be a little bit more specific to, maybe not engaging in physical activity or exercise. So sedentary behavior, and that might be, for example, what I'm engaging in at this time, such that I'm in a chair, and maybe I'm on the couch, maybe there's just not a lot of movement that's occurring, so there's not much energy expenditure, for example, that's being produced from any sort of musculoskeletal or neuromuscular movement. But there's also physically inactive. And physically inactive maybe is a little bit more specific to not achieving physical activity guidelines. So looking and examining those two terms, for example, it is possible to engage in sedentary behavior but still be physically active. But maybe physically inactive would be representative of high levels of sedentary behavior. And I mean, there's a lot of guidelines that do exist. I spoke a little bit about physical inactivity and how that connects to maybe the physical activity guidelines not being achieved. And there can be some differences with different physical activity guidelines that do exist depending on a variety of factors. But when thinking a little bit about physical activity guidelines, it's oftentimes connected to the physical activity guidelines for Americans, which were first generated in the year 2008, were updated in the year 2018, and we're expecting again another update in 2028. So about every 10 years or so. And in brief, here are the physical activity guidelines for Americans that are proposed, and that is greater than or equal to 150 minutes of moderate to vigorous physical activity each week. Maybe when considering muscle health, engaging in maybe major muscle groups, multi-joint movements for maybe resistance training at least 2 days a week, and just generally speaking too. Trying to make it a point to maybe just move more overall and sit less. There is some information to suggest that there's high levels of sedentary time in adult populations, for example. Some evidence suggests too that during waking hours, persons might be sedentary for approximately 9 hours per day. So that's a high level of sedentary time as a whole. So noting that we maybe need to make it a point to just move more and engage in less sedentary time may help to reduce that level. So noting that there could be some situations where during waking hours, adults are engaging into approximately 9 hours of sedentary time each day. There could be some challenges in meeting the physical activity guidelines for Americans, for example. The diagram on the left is just an example of the proportion of adults in the United States that might be achieving the physical activity guidelines for Americans, and approximately half or so are meeting neither guideline for aerobic or muscle strengthening activities. And the figure on the right, for example, would be looking at achievement of physical activity guidelines, maybe just in classification of age demographic. And we're noticing a little bit of a downward trend, both in men and women, such that as age maybe advances in older adults, for example, looking at the proportion of persons that might be meeting the guidelines, persons that are in the classification of 65 and older are not meeting the guidelines as outlined on the previous slide. But there can be some unique challenges that do exist in engaging in physical activity, meeting the physical activity guidelines for Americans, for example. And this is a diagram that maybe it would help to represent maybe some of the limitations that do exist with achieving physical activity guidelines for Americans. So we do have different classifications of intensity of physical activity. Maybe that's light physical activity, moderate physical activity, or vigorous physical activity. But the colorful diagram that's in the middle might help to be representative of the amount of time that persons might be actually spending in each of those categories during the day, such that there's high levels of sedentary time that may exist. For example, in adults, maybe that's around 9 hours per day. Maybe there's some light physical activity participation, but moderate to vigorous physical activity participation may not necessarily be long in duration in a given day. But we do have physical activity guidelines that specify moderate to vigorous physical activity, 150 minutes, for example. But there's not necessarily a bridge to get to that physical activity guideline, which can be challenging. So considering maybe light physical activity, for example, could be important, not just for like health benefit, for example, but maybe springboarding and progression toward achieving the physical activity guidelines and adherence to engaging in physical activity is important. So it's good to note that the physical activity guidelines for Americans are just a guideline. There are some limitations that do exist. And light physical activity certainly is a very important classification of physical activity intensity. And looking at maybe the health aspects of physical activity too. Generally speaking, there's a fair amount of evidence to suggest that engaging in physical activity regularly is just overall good for health, and it's overall good for health across the lifespan. It supports extended longevity, helps to reduce the risk of maybe chronic cardiometabolic diseases, perhaps hypertension, perhaps diabetes, factors related to body composition, which may include body mass index. We had a very nice presentation just before this presentation that was dedicated to factors related to ADLs and basic self-care. And physical activity would help to support maybe an ability to continue to complete basic self-care tasks and mobility. Factors related to mental health, factors related to physical health, maybe bone health. Muscle and bone health are oftentimes connected. So thinking a little bit about osteoporosis and fractures that might be related to falls is similarly important. And then there's similarly a strong connection for the association between physical activity participation and dementia. When thinking about programs for physical activity, maybe physical activity interventions, there can be different types of interventions that do exist. We're going to see this slide again later, but I'm going to focus, at least for now, on primary care, which might be dedicated to programs and interventions that would be specified to prevention of the condition before it is present. And thinking about maybe trying to springboard or upscale physical activity participation to help prevent a health condition. If for a person that may not be accustomed to engaging in physical activity, there can be some very unique challenges that do exist. Maybe it's challenging to sometimes change habits, for example, and being in a comfort zone and stepping outside of the comfort zone and maybe trying something different. If that thing that is different is physical activity, can be challenging. It can be intimidating. So there are some differences that do exist. And not necessarily, I mean, examining the role of physical activity, being active, being not active, but just looking at the spectrum, looking at things on a continuum. Perhaps it's thinking about being physically active or planning to be physically active, for example, before actually participating in physical activity is an important stepwise process to adherence to physical activity, for example. There's a lot of decision making that does go into participating in physical activity sometimes, such as what to do, where to do it, factoring in physical activity in a given day. So there's a lot of planning that sometimes takes place, and decision making is certainly a factor. And maybe sometimes physical activity is maybe novel. A person may not necessarily have experience engaging in physical activity. Perhaps previous experiences were not pleasant. So engaging in an activity that may have a history of not being pleasant, can be very challenging too. Similarly, there are barriers that do exist to participation in physical activity. I spoke a little bit about on the previous slide time. Time is most certainly a barrier to engaging in physical activity. Busyness can be certainly present for adult populations, and trying to find time to be physically active or engage in exercise that is structured can be hard, depending on situations, of course. Social supports, there is good evidence to suggest that social supports, engaging in social behaviors, accountability, it does help to support physical activity participation. Maybe there's not a lot of energy to engage in physical activity because of the busyness that might be present. So energy to participate can be challenging. Motivation similarly just may not be present, or if maybe one of those unpleasant experiences from engaging in physical activity included an injury, may not necessarily be interested in engaging in physical activity again because of factors related to injury risks. Maybe physical activity includes joining a wellness facility. Maybe it includes equipment, for example. And with that can sometimes come costs or even access limitations. And in a state like North Dakota, for example, which does have 4 seasons, there can be transitions as to what you do for physical activity, such that maybe during summer months, physical activity is conducted outside, whereas during winter months, it could be more challenging to engage in physical activity outside, and alternatives to maybe something more indoors are present. There are some behavior change models that do exist that are dedicated to behavior change theory. And this is an example of one of those behavior change theories. That is the trans theoretical model. And it helps to maybe determine and examine factors related to readiness to engage in physical activity. And it's kind of done through certain stages, certain classifications. Those certain classifications can change over time. Factors related to lifespan may help to change trajectories over some of these changes. And it can be a multi-month process, for example. So changes that do happen across the lifespan and new barriers that may present themselves may help to serve as an inflection point of sort for maybe physical activity participation as we go kind of like up and down this classification, for example. And then maybe there's a pre-contemplation stage such that there's not really readiness to engage in physical activity. A person won't engage in physical activity or can't be physically active, for example, because maybe there's just too many barriers, or maybe there's not an identification of maybe high levels of sedentary time being of concern. So maybe not wanting to make any changes in physical activity habits, for example, and therefore it can be very difficult to change behavior as it pertains to physical activity participation. Next classification is the contemplation stage, wherein a person may engage in physical activity or they might engage in physical activity. But here there's at least some acknowledgement that there's maybe a problem in thinking a little bit about being physically active and weighing perhaps the pros and the cons of being physically active and trying to find time to perhaps to be physically active. Preparation stage, maybe there's some intention to be physically active. Maybe a person is saying that they will be physically active. Maybe there's some planning to be engaging in physical activity. Sometimes during this stage, some education can be important. Maybe some conversation can be important to help to identify situations to overcome barriers to being physically inactive. During the action stage, perhaps the person is actually being physically active, and there's a time commitment and effort commitment that might be new. It might be a little bit large, and certainly something that a person may not be used to. So looking at alternatives to continue to maintain adherence to physical activity could be important. Looking at situations where there can be opportunities for progression certainly will support physical activity adherence when in the action stage. And then finally, in the maintenance stage, a person has been physically active for maybe a longer period of time. Looking at situations to maybe avoid relapse from the maintenance stage, for example, may include just looking at situations that would help keep things fresh. Maybe trying new things, for example, and trying to navigate maybe new barriers as they present themselves across the lifespan. Another behavior change theoretical framework that is present and related to motivation is the self-determination theory. And there's three kind of like pillar characteristics that do exist with self-determination theory. Autonomy and the ability to select physical activity or have choice in physical activity. Competence, which might be connected to knowing how to be physically active or having a background or an education in physical activity. And relatedness, and that kind of connects to that social component that I suggested on an earlier slide, such that having relatedness, having some social supports would certainly help to improve motivation to be physically active and adherence to be physically active. And within the self-determination theory, there's different layers of motivation that do exist. There's amotivation, there's extrinsic motivation, and then there's intrinsic motivation. And with amotivation, there's no motivation to be physically active. Probably connects to the trans theoretical model, where maybe there is just a lot of barriers that do exist. There's not really a lot of motivation to change. So behavior change in this regard can be quite challenging. Within extrinsic motivation, there's different levels of regulation that do exist. So external regulation is one of those levels, which would be then, in this case, the lowest level of extrinsic motivation. And that maybe is driven by perhaps goals or reward, for example. An example might be completing 100 push-ups in a given day in order to have a prize. As we kind of continue to move from left to right within the regulation categories, we have introjected regulation. Perhaps that's an example of maybe being part of a walking group for peers. Identified regulation might be specific to goals or values. An example here might be a lifelong goal is running a marathon. So engaging in physical activity to achieve that goal might be important. There might be integrated regulation too, where physical activity participation and motivation might be dedicated to maybe identity, for example. And then intrinsic motivation, where truly internal motivation is from within to engage in physical activity. Enjoyment is very high. Perhaps autonomy, relatedness, and competence is similarly high. And I just, I think a little bit about my physical activity participation across the lifespan and where I am now, where I can like to continue to be. I'm probably intrinsically motivated or factoring into maybe the integrated regulation classification. Physical activity maybe is part of my identity for health, for example. There are some situations where maybe just that's something that I choose to do because I have true enjoyment from it. So in those cases, maybe motivation as it relates to maybe self-determination might be quite high. There are trends that do exist as presented by the American College of Sports Medicine, which tends to be the largest or one of the largest governing organizations as it pertains to exercise science and sports medicine, for example. And we kind of see maybe where these trends are in 2026. And one thing that kind of stands out that I've kind of noticed and highlighted here is trend number 2, which is fitness programs for older adults. And in my experience, speaking a little bit more anecdotally too, I'm starting to see fitness programs that are being presented that are specific to older adults, and we're starting to see that that's a good thing, because when we're thinking a bit about the older adult demographic, for example, there are some projections to suggest that there's going to be a population demographic shift such that we're in future years going to be experiencing perhaps 113% in the older adult demographic. We might be experiencing these population demographic increases locally, nationally, and globally. The infographic on the left even suggests that by the year 2034, for the first time in history, that the proportion of older adults may outnumber the proportion of youth. And kind of looking at maybe older adult demographics, examining maybe the healthcare needs for older adults, and kind of having a healthcare support system that would be in place to support the health needs of the rapidly growing older adult demographic. That may include workforce demand, that may include housing, for example. But with maybe an older adult demographic comes maybe situations where there's some age-related conditions that might become present, or the incidence of a condition may increase. So when thinking a bit about maybe trends in dementia, for example, by the year maybe 2060, we're looking at roughly maybe a 15% proportion for older adults that might be living with dementia. And looking at proportions and looking at projections in the future, and maybe in future years, for example, is definitely important. But kind of examining what might be happening retrospectively does have value too. And this diagram does kind of suggest looking at different age classifications and the role of Alzheimer's disease related dementias, perhaps looking at prevalence, dementia-related mortality incidents, which might be new cases, and disability-adjusted life years too, which tends to be a summation of years lived with a condition and then likewise years of life lost due to that condition. We're kind of seeing some increases and looking at maybe some trends that just jump out when eyeballing each of these diagrams. We're kind of seeing a little bit of a spike for maybe 50 to 54 years, 55 to 59 years, and 60 to 64 years, just kind of when eyeballing these trends too. So when thinking about the role of dementia and dementia-related outcomes, kind of seeing some spikes to couple with maybe that growing older adult demographic. And physical activity is important when considering the role of cognitive functioning. This is a diagram that maybe is classified into different age demographics. So we have early adult life, midlife, and late life. And this is examining physical activity participation with a physical activity index, and 1 maybe being the lowest levels of physical activity, and 5 being the higher levels of physical activity. And when comparing, maybe like group classification number 4, classification number 5, to maybe classification 1, which is again the lowest active group, maybe seeing some differences that do exist for midlife and later life, such that risk for dementia might be lower when physical activity participation might be higher. When looking at things for objectively measuring aspects that would be connected to physical activity, that can include factors related to muscle health, muscle strength. Muscle strength, though, can sometimes be uniquely challenging to measure in clinical and community settings. There is some rationale for that. Equipment can be large, it can be expensive. Movements can be challenging. Perhaps it has limitations with inclusiveness, for maybe functional limitations, for example. And then also persons administering tests may have to have some knowledge and background and training as to how to complete some of these tests appropriately. So there is a convenient and reliable assessment that does exist, and that's with hand grip strength. And hand grip strength is oftentimes measured with hydraulic hand grip dynamometers, such as what's outlined on the image on the right, such that we would squeeze the dynamometer as hard as we can, exhaling while squeezing for probably about a couple of seconds, and then release. It's an isometric contraction, so that means that there's no movement, even though that muscles are working. And we would maybe do 2 to 3 trials on each hand, and the highest recorded hand grip strength value is representative of overall muscle strength. And hand grip strength has been identified as being robustly associated with factors of cognitive impairment. And here we have some evidence to suggest that it tends to be one of the higher level or top risk factors, maybe for early onset dementia. And then when looking at maybe incident cases or new cases of dementia, as hand grip strength increases, which would be more reflective of higher levels of muscle strength, the risk for incident dementia decreases. And there can be some rationale to help to support why we're seeing an association with hand grip strength, which is reflective of muscle strength and cognitive impairment. For example, one of those rationales may include that the neural systems that help to support the fine motor skills for completing a grip force task, such as hand grip strength, might be the same neural systems that are connected to cognitive functioning. So there's shared neural systems that are existing. So if there is onset impairment in cognitive functioning, then that might be connected to being able to complete a grip force task, because there is a shared system that does exist. There are also some clinical trials that do exist that are examining the role maybe of physical activity on Alzheimer's disease related dementias. One of those clinical trials is the US Pointer study. And this trial specifically found that, in brief, targeted structured intervention that does include factors like physical activity, maybe nutrition, maybe cognitive tasks, maybe social tasks, for example, and health monitoring may help to support cognitive functioning in older adults that might specifically be at risk for cognitive impairment. So we kind of see some of these factors too, and we're seeing moderate to vigorous physical activity multiple times a week, perhaps an effort to help to achieve the physical activity guidelines for Americans. Maybe there's some cognitive tasks that might be specific and computer-based with respect to this intervention that might be fruitful for preserving cognitive functioning during aging. This investigation examined factors related to the MIND diet, which tends to be maybe a combination or hybrid of the Mediterranean diet and the DASH diet, which may include, for example, leafy greens, berries, nuts, fish. And then visiting healthcare provider routinely to maybe check in, to maybe monitor changes and provide intervention as appropriate. So there can be some situations where engaging in healthy lifestyle behaviors may have factors in preserving overall cognitive functioning and helping to change some of those trajectories that may exist as it pertains to overall cognitive functioning. So, for example, there can be some trajectories where engaging in physical activity and other similar healthy lifestyle behaviors can help to preserve cognitive functioning or time to incident dementia during the aging process, where maybe not engaging in healthy lifestyle behaviors would maybe accelerate time to an adverse health outcome. And we see in this example maybe some trends or some curves that are existing for maybe cognitive functioning. We see similar trends too when examining factors related to muscle health, maybe muscle strength and mass, and how engaging in healthy lifestyle behaviors can help to support higher levels of muscle mass and muscle strength because during the aging process, we oftentimes experience age-related declines in each of those physical attributes. So overall, when examining the role of physical activity in primary intervention and prevention as a whole, physical activity for health, including cognitive functioning, it's certainly encouraged. Never necessarily too late to begin. Engaging in physical activity does have a multitude of health benefits. And I spoke a bit about the higher levels of sedentary time that do exist, or the proportion of persons that may not necessarily be meeting physical activity guidelines for Americans, and having some reminders, taking breaks in sedentary time, having an opportunity to stand from the chair, go for a walk, have a walking break, can be a very nice method for helping to break up long bouts of sedentary behavior. Thinking a little bit about the barriers that do exist, also the facilitators that may help to support physical activity, looking at opportunities to improve motivation and readiness to engage in physical activity, and then eventually think about maybe frequency intensity type time. But acknowledgement that, again, there's barriers that are present. Maybe creating a new routine from habit can have some challenges. So engaging in physical activity isn't necessarily always easy. So physical activity for primary care when we're trying to prevent a condition such as dementia is certainly important, but there might be circumstances where maybe cognitive impairment is present, but maybe physical activity is still recommended. And maybe in those scenarios, we're going to have a little bit more of a focus on secondary intervention and even in some cases tertiary intervention. So when examining maybe secondary and tertiary intervention for persons that may have a dementia diagnosis, when examining Alzheimer's disease related dementia, there's a very, very large proportion of persons that may have that diagnosis that also have maybe another chronic condition. So thinking a little bit about the role of multimorbidity and how that might be impacting health and how maybe physical activity participation may help with supporting maybe other conditions that might be present. When examining maybe some of those other conditions, physical activity certainly has a strong connection to factors related to blood pressure, maybe has factors related to diabetes markers, for example. So, there is maybe benefit for physical activity participation for cognitive functioning, but there also might be benefit for physical activity participation for other morbidities that might be diagnosed in some cases. So having some acknowledgement that persons that have a diagnosis of Alzheimer's disease or Alzheimer's disease related dementias and might be living with another chronic condition, it's important to note then that physical activity may have benefit for those other conditions. Apart from maybe some of those other chronic conditions, there are also other benefits to engaging in physical activity when dementia might be present. There could be some situations where there's high levels of sedentary time. And opportunities to take breaks from that sedentary time may help with soreness from sitting or soreness related to the bed. So improving circulation in that regard. Thinking a little bit about fall risk, thinking a little bit about maybe behavioral and social factors, and trying to engage in physical activity to help support some of those factors does have benefit. Some of our earlier lectures spoke a little bit about the role of sensory, and sensory can come in unique forms, can be visual, can be looking at contrast, can be looking at a color. Perhaps there can be factors related to touch, for example, that would help to improve sensory experiences. So looking at opportunities to perhaps have factors that would be sensory specific certainly may be conducive to a good physical activity participation when cognitive impairment might be present. But also kind of maybe consulting with a healthcare provider, looking at maybe the role of maybe some of those other conditions that might be present, and trying to be safe with physical activity participation when possible is very important. Maybe a healthcare provider, a caregiver is helping to support physical activity in persons with dementia, and making sure that those support systems are in place, knowing how to start a physical activity, maybe making sure that physical activity is fun. Can physical activity maybe be done independently or with some supports or helps? Maybe observing if there's some challenges that do exist, and making note of maybe having fun, celebrating those successes, certainly supports enjoyment, certainly supports adherence. Intensity of physical activity, light physical activity, moderate vigorous physical activity. That is certainly a consideration, but there's a lot of types of physical activity that might be fruitful. Thinking a little bit about functional abilities, the presence of maybe other conditions that would help to maybe guide physical activity participation is important. But even going on simple walks, going through indoors and taking breaks in those sedentary times is certainly important when possible. Again, kind of getting back to that sensory experience and the role of music. Music can be something that can help to support maybe cognitive functioning, and can be something that would help to stimulate physical activity participation in the form of dance, or even taking breaks in that sedentary time. There can be some balloon activities that would be helpful for maybe motor tasks, for example, such as maybe throwing balloons, or having fun with the balloons and pushing them in the air, for example, or even leisure activities or household activities such as gardening, and doing related tasks can also be a nice support method for engaging in a light physical activity. So consulting with healthcare providers is good for physical activity participation, whether it might be in primary, secondary, or tertiary intervention settings. So checking in with a healthcare provider about physical activity participation is important to help to springboard physical activity and support physical activity. Noting the barriers that do exist and how that changes across the lifespan, acknowledgement as to how that may impact physical activity adherence and readiness to engage in physical activity could be noted. Noting too some of the things that may come up, and helping to support maybe physical activity in the form of music, sensory experiences, and other factors that may help to guide physical activity is, I think, important to operationalize and understand before engaging in physical activity. And then also noting how to assess physical activity, changes in physical activity habits. Is physical activity being monitored maybe on a wearable device? So you can kind of see maybe if the activities that you might be engaging in or the support systems with interventions are demonstrating effectiveness.